Welcome to Decoding DX. We're a group of fourth-year medical students with a passion for education and patient care.
This episode of Decoding DX is for educational purposes only and should not be used as medical advice. Please consult your healthcare provider for any medical needs.
The opinions expressed represents those of the participants and are not of our affiliated institutions.
Thank you for joining us on Decoding DX. We keep learning so much through this experience, and we're so glad that you're learning alongside with us. Now, let's get to the episode. Hello and welcome to 10 Clinical Minutes. Today is part one of a two-part series on insulin in the hospital. Part one will be on what do you order on admission. Part two will have some examples in special circumstances. To start out, just to clarify, we are not talking about critical care patients or DKA. We are talking about non-critical care patients with diabetes who happen to be admitted to the hospital. So let's say you're in the ED, you're admitting a patient for any of these reasons or many other reasons, something other than DKA, just any other reason to come into the hospital. You note that they have diabetes and they take metformin and empagliflozin, one of the GLP-1 antagonists. What do you order? What do you start on admission for blood sugar control? The empagliflozin isn't on formulary. What about if they are on a home insulin regimen like glargine? What do you start then? Does it depend on what they're sick with? One question you might need to start with is if you need to order an A1c. According to the American Diabetes Association, you should order an A1c on admission for anyone who has known diabetes or they're hyperglycemic on admit and they haven't had an A1c done in the last 3 months. This is to kind of establish a baseline. This can help you a lot just to get a better context of what their diabetes control looks like, and it can also help to guide your management once you look at discharge. And I think this is important to note that hospitalization can be a really important time where we can intervene for some patients that may not follow up on outpatient therapy or may not have a good understanding of their diabetes or their medications. So being in the hospital gives us an opportunity to really educate our patients and get them on a better track for when they leave the hospital. Of note, this evidence is grade B evidence, which comes from supportive evidence from high-quality cohort studies. So another question we might ask is, can I continue the oral meds? Short answer, probably not. There's a lot of reasons for this. The literature is kind of conflicting, but in general, the consensus is you should hold the home meds and start insulin on admission. There's a lot of reasons for this, including delays of management. For example, we usually hold metformin in the hospital because if we need to do a stat CT scan or other scan with contrast, it can complicate that picture if they've been on their metformin, because the recommendation is to hold the metformin for 24 hours before IV contrast. You also have higher risks of side effects with some of these oral medications with acute illness, and so it just kind of simplifies the picture when we have a complicated patient with an acute illness if we stop those home meds and just start insulin that we can control. Longer answer, if they meet certain criteria, there might be an argument for keeping those oral meds while they're in the hospital. Number one, though, if those meds aren't on the formulary, you don't have an option, decision's made for you. So if you do have some of those medications that are on your formulary, for example, some hospitals do have metformin on formulary, you can consider keeping that if you expect them to have a short hospital stay, you don't expect any major disruptions to their eating patterns, they're not critically ill, there's no other contraindications with their admission, anything like that. If it's a short hospital stay, like an overnight observation, you can consider continuing their home medications. But again, it's usually better to play it safe and go ahead and stop the oral meds and start insulin. Next question, what is our target blood glucose? Short answer, 140 to 180 milligrams per deciliter. Longer answer, again, there are some instances where these guidelines can be lower, like if the patient has type 1 diabetes and they have very good control over their insulin and they don't want to have a higher range and they're not critically ill, you can consider a lower goal. But in general, when our patients are in the hospital, we want to target a higher blood glucose level because we know that the risks of high blood glucose are more of a long-term issue, not a short-term issue. And when our patients are critically ill in the hospital, there's much higher risks associated with hypoglycemia than hyperglycemia. So it's much safer to err on the higher side of glucose while the patients are in the hospital so that we don't further complicate their illness by having episodes of hypoglycemia. And the recommendation for that 140 to 180 is actually a very clear recommendation with grade A evidence, meaning that there is very clear evidence from high quality RCTs. This is a quick chart of the different types of insulin with the current generic and brand names along with their costs in the United States. I'm not going to go through these. This is here for your reference. You can pause the video and go through this as is relevant for your information. Okay, so back to our question. What are you going to order on admission? Well, there's two main ways of administering insulin that you can think about. One is basal bolus. This most closely mimics the natural state of insulin in the human body. And the idea is that you have a low level of basal insulin that's long-acting, that's always there. And then you have boluses or peaks of extra insulin when the patient eats. This by far has the best glucose control. And again, it's best for helping our patients' bodies heal as they're critically ill. This is the regimen that you should do when you're in the hospital. Even outside of the hospital, this is the best regimen for our patients. That's a whole different discussion of outpatient management, but in the hospital, you should be doing basal bolus. The other strategy is sliding scale insulin. This is going out of favor for really good reason. Again, we have this recommendation from the American Diabetes Association with grade A evidence to not use the sliding scale insulin pattern. Essentially what this is that you're taking point of care glucose measurements every 4 to 6 hours, and then you're dosing that insulin based on their blood sugar measurement at that time. So the biggest problem with this approach is that it's actually reactive, and this leads to really high highs and really low lows. Because let's say, for example, a patient has a high blood glucose. You're going to give them a high dose of insulin, which then is going to tank their blood glucose. And then you'll see that glucose next time, and you'll maybe give them some orange juice or something else to bring that sugar up. And then that's going to get their blood sugar really high again, which is then going to cause you to give a high dose of insulin. And you can see this can become a very rapid cycle that can go up and down and have the patient going through very significant extremes of blood sugars. So long story short, don't do it. There are extremely few situations where this is appropriate on the inpatient side, and that's typically for very short durations of time. In general, you should not be using sliding scale insulin. Okay, so how do we choose our dose? If your patient is already on an outpatient regimen, you can continue that same dose. If they're not critically ill, they're eating as normal, you don't expect a decline in their clinical status. So let's say they're admitted for cellulitis and they're not septic. That would be maybe a situation where you can continue that same dose. You may want to consider decreasing their dose. However, if they are maybe not taking in as much, if they're nauseous, if they have diarrhea, if they're hypoglycemic on presentation, a lot of this comes down to the art of medicine. If you feel like they are not at their normal status as far as eating and what you would expect of their blood sugars, you really shouldn't be giving them the same dose of insulin. It's really important to remember that the patient always needs some level of basal insulin. There's very few exceptions to this. Even if, let's say, they're NPO for procedures, they need to have some level of basal insulin on there. The reason for that is, the normal body always has some level of insulin. That's why DKA gets so severe, is because there's no insulin. So we don't want to put our patients into a DKA type state by withholding their basal insulin. Their rapid acting or meal dose insulin, on the other hand, you can hold. If, for example, they're NPO, they're just really not eating much, they're super nauseous, those would all be great reasons to hold their meal insulin and only dose it if they do in fact eat. Okay, so what about when you have a patient that's on oral meds and you're newly starting insulin on admission? For example, if they're on that metformin and empagliflozin. You need to start out by calculating their total daily dose. And you're going to do this by multiplying their weight in kilograms by anywhere from 0.2 to 0.5. And where you figure out in that range depends on kind of the clinical picture of your patient. So some examples where you might want a lower dose, so like a 0.2 to 0.3 per kilo, would be if they're type 1, if they're elderly, if they have chronic kidney disease, if they look medically fragile, if they're very sick. Those would all be reasons to start low. Starting high would be if they have type 2 diabetes, their blood sugar is pretty high on admission, like above 200. If you suspect just from their clinical picture that they have high insulin resistance, metabolic syndrome, those would all be reasons to have a higher dose of insulin to start on the 0.4 to 0.5 range. You're then going to split that total daily dose into 50%, which is going to be your basal dose. So that's going to be your glargine, detamere, or NPH, depending on what's your formulary. You can give this once a day, typically at night, or you can divide the dose depending on the half-life of the insulin and the blood sugar control that you're trying to get. That other 50% is going to be the short-acting insulin, like Aspart, Lispro, glucine, or regular insulin, again, depending on what's your formulary. You're then going to divide that 50% number by how many meals the patient's having, which is typically 3. So for example, if you had a total daily dose of 24 units, you would have 12 units of insulin in a basal, like glargine at night, and then you'd have 12 divided by 3 or 4 units per meal of short-acting insulin. In addition to that, you want to add on a correction factor, and this is to help you adjust when you're starting a new dose of insulin and you don't know exactly what that patient's insulin requirements are going to be. To start off, do about 5% of your total daily dose and see how much that is. And you're going to give this correction factor before meals or every 4 to 6 hours if they're not eating. You'll commonly see these as order sets in the EMR. So a low dose correction factor will be 1 unit per amount of blood sugar over 180 by 40 units. So that's super complicated. But for example, anywhere from 180 to 220, you'd give 1 unit of correction factor. From 220 to 260, they would get 2 units of correction factor. And then medium dose is the same blood sugar increments, but with 2 units per 40 increment. And then high dose is typically 4 units per 40 increment. So that's super complicated. Please watch our part 2 of this series, and we'll have some examples to walk through this a bit more clearly. So as you're putting in the order, in most institutions, there's going to be an order set. It's going to be something along the lines of adult subcutaneous insulin or adult diabetes insulin or something like that. It's really important to do the order set because this will have all of the other orders that we wouldn't otherwise think about to put in with our insulin. So you're going to have communications to the nurses for when they need to contact you. For example, if the sugar is below 70 or if it's above 300, they need to contact you. This will also typically include orders for a diabetic diet to make sure that our patients are having carb counting controlled diets while they're in the hospital. This will put in all the orders for the point of care blood glucose checks that the nurses need to be able to dose the insulin properly. You can have the option to consult services that can help with that inpatient management, like the dietitian or the educator. Again, going back to the idea that an inpatient setting can be a really good intervention time to educate our patients. And just to note, this is a panel with a lot of different orders. You're going to have multiple different orders of insulin itself because you're going to have your basal, you're going to have your bolus, you're going to have correction factor. Sometimes you can have those boluses as either pre-meal or post-meal. The reason that you may want to do post-meal is if your patient's not eating a whole lot, then you can dose based on how much of their meal they ate. So for example, if you had a dose of 10 units per meal, but they're not eating that much, they only ate half of their meal, they'd only get those 5 units of insulin since they didn't eat that much. And just make sure that you remember, modify as is appropriate. There's no one size fits all for our patients. Take your patient in the context of who they are individually and adjust these order sets as is appropriate. Some key points. If your patient is already on insulin before they come into the hospital, continue their insulin or adjust based on their clinical status as you assess. If they're on oral diabetes medications, you probably are going to need to start insulin while they're inpatient. You can estimate their total daily dose. No more sliding scale insulin. Let's stick to basal bolus. It's better for our patients, better for outcomes. Err on the side of hyperglycemia when you're deciding a dose. We can always add more insulin. That's safer than risking hypoglycemic episodes. And finally, watch the trends and adjust accordingly. Here are some references. Thank you so much for joining us. Follow up with our part 2. We're going to have some examples to walk through this to have a little more clarity.